So without further ado, I'd like to go and introduce our first speaker, Tom Chiller. He's chief of the Narcotics branch at CDC, is going to give us 20 minutes on kind of the CDC perspectives on this, how CDC looks at this, how they view it, initiatives that have occurred within the CDC. And with that, Tom, thanks again for agreeing to do this and looking forward to your comments.
Thanks, Pete. Appreciate it. I want to just, before I start, make sure, do you guys see the appropriate screen?
Yeah, looks good.
Yes.
Excellent, because I have multiple screens here, as many of us do in this virtual era. So thanks, Pete, and thanks to the mycosis study group. I'm thrilled and excited that you guys have put this all together in one shop, which is fantastic. We've been talking about, as you mentioned, fungal diseases and COVID for a while now, but it's great to see this lineup. And I'm just going to be brief and really give maybe a few of our perspectives and an overview of some of the things that will be talked about today in much more detail by the experts. So again, I'm excited to sit back and listen as others address. Clearly, we've seen a lot on this in the news, and the fungal infections associated with COVID have hit all kinds of headlines, including changed an entire nomenclature to color schematics, which have been an interesting things for all of us in the infectious disease world, getting these fungi named different colors. That being said, I don't think we are going to continue to refer to them in this way, but it's been an interesting way to look at how the public is seeing these diseases. You know, COVID-19, I wonder, has it really added another chapter to our understanding of fungal disease? People with severe COVID are particularly vulnerable. Fungal co-infections are reported with increasing frequency, associated with severe illness and death. Symptoms of some of these fungal diseases are similar to COVID-19. And we know physician and public awareness is more important than ever. But is that really a new chapter? And as you heard Pete mention, all of these similar concepts have come out with post Aspergillus in influenza. And so, as we mentioned, we sort of saw this coming, at least for Aspergillus. But what I think is different is it's not just Aspergillus with COVID. There are other diseases, in fact, many of the fungal diseases, if not all, that have some sort of association that we're still working out with COVID. And of course, we're going to hear about that in much more detail today. So I thought I would cover a couple of these just briefly, because you're going to hear much more about this from Tom Patterson next up. But we know about this invasive pulmonary aspergillosis as a complication of influenza. There was a lot of low awareness and actually infrequent testing. Similar ideas with what we now call Kappa, COVID-associated pulmonary aspergillosis. A lot of reports out of Western Europe, and really one of the most commonly, at least reported and associated COVID-19 fungal infections. And I'm sure Tom will cover this data, but just to say that clearly having an effect and having a burden on patients who have COVID and unfortunately get aspergillosis. A lot of unknowns that with all of these entities, especially here in the US about Kappa, what the impact on mortality versus simply a marker of COVID-19 severity, as most of these patients, not all, are in the ICU. What does this do for antifungal treatment and prophylaxis? And I know that we've been working with the mycosis study group to try to delve into this in much more detail across multiple centers, and I'm sure Tom will talk about that. Switching now to invasive candidiasis, which you'll hear from my colleague more about, Megan Lyman later on in the afternoon. it's really not your typical candidemia associated with COVID. This is different. Liver disease, cancer, prior surgery are less common in the reported cases. ICU mechanical ventilation, central line steroids are more common. Admission to candidemia seems to be longer versus typically for non-COVID, and maybe inpatient mortality is higher. And this is some of the data that was published recently. Candida auris, the new kid on the block, maybe not so new anymore, increased dramatically during COVID. A brief blip down at the beginning when probably people were too busy to look for it. And then you can see, and Megan will cover this later, but we've seen it now. Candida auris spread to new parts of the US, outbreaks occurring in previously well-contained areas, unfortunately. Most transmission still in these longer-term care facilities, which, as we all know, were at the heart of COVID-19, but also outbreaks in acute care hospitals, frequently in these COVID-19 units. And, again, potentially related to changes in routine infection control and prevention. We also, unfortunately, saw the first cases spreading down into other parts of the Americas, associated often with COVID-19, Brazil, Guatemala, Mexico, Peru, and then an outbreak and multiple outbreaks reported among COVID-19 patients in hospitals, one that we know from in Mexico. Switching gears to COVID-19 associated mucor. Again, we're going to hear more about this from our colleagues, but this really started the color schematic where this was named as the black fungus. We all know mucor is just a medical emergency and certainly a concern in any patient who has it, but now we know a concern with current or recent COVID-19. We'll hear a lot more detail about the India cases, et cetera, but we're also seeing cases in the Americas. And I think it's going to be important to understand why we're seeing these cases. And I know we'll hear more about that, but it's not just an Indian phenomena. We have had multiple cases described in the Americas. You can see PAHO put out an epidemiological alert. This led to the report of actually quite a few cases, including recent clusters in Honduras. We've had cases reported in the US, and you can see in Brazil, Chile, and others. But clearly, there's always been a need for early diagnosis in this disease, and this has really shown us the importance of that. And then finally, talking a little bit about the endemic mycosis, we'll hear from Jeremy and George Thompson on this. But there is some evidence of valley fever co-infections, and I know George Thompson will cover this. Will be interesting to hear how he talks about this as a coincidence or a reactivation or other possibilities. I think described by our colleagues in Kern County as the triple threat, COVID-19, flu, and valley fever, being very hard to discern from each other. And they certainly were very concerned early on in the pandemic about these three coalescing, especially in that part of the country where cocci is so prevalent. I think thankfully we've had a relatively low flu burden, as we all know, and I think we're hoping for another lower flu burden this year. There's also been other endemics, co-infections reported, histo in the Americas, unclear about some of the other endemic diseases. Certainly wider use of steroids and immunosuppressants we think would increase the risk of these symptomatic endemic mycoses. And then again, we'll hear from Jeremy about late reactivation of crypto and maybe its association with COVID-19. And so I'll just end with a couple, final thoughts in that whirlwind tour of COVID-19 and fungal infections. I think it's really important when we think of fungal epidemiology that generally it's local, not so much global. Now we can learn from local lessons and maybe apply them globally and certainly pay attention. But we all know that fungi, at least environmental fungi, are unequally distributed. And, it really depends on the microbiome. We talk about microbiome in patients, but here I'm talking about the environmental microbiome, or maybe the soil microbiome, or the plant microbiome, where these fungi exist. And so really that local epidemiology is important. And I wish certainly in is this environmental microbiome study. And then like for something like candidemia, where it's more of an auto infection, then of course we worry about the gut microbiome, or in the case of C. auris, the skin microbiome. And so I just think one of the things that we're thinking about certainly at the CDC is this phenomenon. And then finally, the public health messages. We know COVID-19 can become complicated by secondary invasive fungal infections. These infections are difficult to diagnose. We'll hear more about that today, and obviously associated with poor outcomes. And so our continued cry for more surveillance, some better diagnostic algorithms, better diagnostics in general, and education to healthcare providers. So think fungus saves lives, as you all know, is our motto. And Pete, thanks for letting me kick this off, and I look forward to a great afternoon of presentations.
Thank you, Tom. And let me ask you a couple of questions because we have a little extra time here. And so could you kind of explain in broad terms, what sort of surveillance can CDC do? Now, you've partnered with the MSG to get a sense of Kappa. But what more can you do? What are what kind of tools does the CDC have at their disposal that can make statements about some of these other conditions? Is it completely dependent on reports that those of us in the outside world provide, or can you do something proactively? What are your thoughts on that?
Yeah, thanks, Pete. I mean, I think, as you know, surveillance for fungal infections, it's something that is not generally happening at the CDC. We have only actually now 2 reportable conditions. One is coccidioidomycosis, and that's only reportable in 22 states. It's a nationally notifiable disease. So if a state chooses to report it, we will get that information at CDC. So that's one. And then the second one that we've made recently reportable is Candida auris. Again, it's state dependent. So for CDC to get information at the federal level, states have to make it reportable. So barring that, then we have to go and look for places to be able to find surveillance information. Probably the best way to do that is to establish our own surveillance, which we've done for candidemia, as you know. So we have 10 sites that give us information on Candida in the US. This represents probably around 15% of the population. This is isolate-based surveillance. So the beauty of that is we get the isolates at CDC and we test them for susceptibility. We can do sequencing on them. We can verify their species, and we can track really well, at least a representative sample of what's going on. This is not real-time surveillance. This is after-time surveillance, but it gives us an idea, at least what's circulating in these 10 states or sites. They're not the entire state. And then finally, there's, administrative data that we can try to pull from. We all know the limitations of ICD-9, ICD-10 coding and what that means. And so we try to do that with some of these databases that are out there, but it's severely limited. So surveillance and improving surveillance and being able to get at data that is helpful and is more real time is one of our big goals here at CDC, certainly in the fungal disease arena. There are obviously other infectious diseases that have much better surveillance than us.
Okay, and another question before we get to our next speaker, Tom. How might you approach the real challenge of a very high burden of COVID in the community? Which, certainly if you live in a state like we do in Alabama, where probably 20% of the population has had natural COVID infection or more. So with that kind of background incidence of disease, how can you determine the relatedness of some of these fungal infections to the COVID? Now, for things like Aspergillosis, where it's occurring right at the time or during a period prolonged intubation or something, it's maybe a little bit easier. But how can you be more clear about the relatedness of COVID to the development of these infections?
Yeah, I mean, these are always challenging questions when you're dealing with somewhat rare disease and in a specific patient population where there are lots of other risks and lots of other things going on. But the basic way we do these sorts of studies is we try to find an appropriate control group, and so you have to have an appropriate control group to compare your new group of patients with this infection to a similar population of patients without or with the infection. And it could be at a different time period, a more historical control, but better would be during the exact same time period and collecting information on a control group with similar risks, and then trying to understand whether there's a higher risk of having that infection in these patients than versus the control group. Those are, as you know, hard sometimes to do, but that's why when we try to collect case information, we also try to collect control information at the same time.
Okay. All right. Well, thank you, Tom. It's very helpful. It's a good start to our discussion. So